over 3 million cases. And this is really concerning. And we are keeping a close watch on the situation. And the regional office is working with the countries in order to improve surveillance and capacity at the country level to deal with this outbreak of dengue. The rest of the Asian region, as you know, the monsoon season has just got started, and it is we anticipate increase in cases, but already the cases have been rising in Philippines, Malaysia, Vietnam, Thailand, and Bangladesh. And we feel that more cases will be reported in the coming weeks, because soon after any flood, it takes about 6 to 8 weeks for an outbreak to begin. And we have already alerted, and part of the objective of this webinar is to have a greater advocacy to make sure that governments and communities are better prepared, especially in parts of Asia where we anticipate more outbreaks after the post-monsoon period. The global trend of dengue is, as you can see in this graph, clearly shows that 2019 was by far the worst year, where we recorded over 5 million cases. But even during the COVID season, we did have dengue, and there were dengue reported all through the year. 2022, we had quite a number of cases, and we expect 23 also to be a bad year, as indications are. And this trend is really a matter of concern. In terms of mortality, it is more or less the same trend. And but the good news about dengue deaths is that with sound case management, the case fatality rate in majority of the countries are below 1, which is very, very good. But it also helps us to monitor that the management of, since we don't have any drugs nor an effective vaccine, we know that the medical faculty especially are doing a great job to manage severe cases in hospital and reduce fatality. The biggest interesting trend here is that even Nature had reported this, that dengue is the only communicable disease which has increased by almost 8-fold since the year 2000. And this graph clearly illustrates that the dengue cases have exponentially increased. And it, as I said in the beginning, it's a silent arboviral disease which has expanded, and we need to do a much more work, concerted work, to deal with this disease. The biggest challenge we face is that 80% of the cases are asymptomatic, and this calls for burden estimation. So countries are encouraged to do burden estimation, and this is an example to show that even countries are reporting, for example, in 2018, the country reported about 10,000 plus cases, 24 deaths, but actually when you really do a thorough study of the burden in the whole country, there were about 7,900 severe cases. Dengue fever itself was over 500,000, and there are more asymptomatic cases. So this part of the pyramid, we don't really record in health systems. And unless or until we capture that part of the pyramid, we cannot use it for greater advocacy, because we need to convey this message that dengue is a silent disease with 80% being asymptomatic, and we won't know much about it, to our political leaders, so that they are fully aware that when a second serotype comes over, we could have more severe cases. And this is an alarm bell which we really need to highlight, because dengue needs a much greater advocacy in terms of the burden. It's a really high burden disease, and we need our political leaders to accept this and move this disease into a programmatic mode, because we need to treat it as an endemic disease with epidemic potential, and we have to move as a control program. We have also, starting this year, we will encourage countries to do more insecticide resistance monitoring, because we have done for the first time a multi-center study which concluded the discriminating dosage from 23 laboratories all over the world. And for the first time, we have separate discriminating dosages for Aedes, and you can download it from this document. We also need to, as I look forward in the way forward, we really need to see that dengue is in a very interesting situation. It is not a bleak environment. We have a lot of developments as we move forward. First of all, in diagnostics, we have several multiplexes under development, and industry is keen to promote this, which will probably diagnose a whole range of arboviruses, and this is encouraging, and we hope good quality diagnostics will be made available soon. There are better tools for surveillance today. So we can tap on the new surveillance systems which are in place for COVID and other integrated disease packages and improve surveillance, both for entomology, epidemiological surveillance, as well as the lab surveillance. Case management is improving significantly. As I said in the beginning, the case fatality rate is below 1, and we hope, and our goal is to reduce deaths to 0 by 2030. This is the global target. In terms of vector control, there are several sustainable tools in the pipeline. We hope to come up with recommendations on Wolbachia soon, at least for the replacement method. Then the suppression Wolbachia is also undergoing studies, along with sterile insect technique, spatial repellent, and also targeted indoor spraying, which is something which got delayed due to COVID, but I understand the studies are ongoing right now. There are also vaccines in the pipeline. We have one vaccine which is registered, but with limited use. But there is 2 other vaccines in the pipeline, which we hope will come up with their recommendations in due course. As I said in the beginning, we really need to include all these innovations in the health system and integrate into existing programs wherever feasible. Just to conclude, I really want to highlight that dengue is a problem linked closely with climate change, and we need to find ways to mitigate it at every country level. The climate refugees is also linked with movement of vectors. As I said, the vectors are continually moved, and these vectors were present in half a dozen countries before 1970, but today they are present in over 130 countries. The increased urbanization and possible large-scale outbreak is real, because our biggest problem is dengue affects urban pockets. And when it affects urban pockets, the population at risk is huge, and we really need to be on guard. We need to use the lessons from COVID. For example, can we tap on the diagnostic platforms, especially the PCR, enhance surveillance, including burden estimation? There is much better methods of communication, factual communication to be made, and we have learned a lot during this COVID period. We can utilize that. How to involve communities? We need to address this in a much more comprehensive way. And lastly, we also need to address gender equity and the human rights issues right through in our documents, and we hope that the dengue situation will improve in the coming years as we get all these tools together. So with that, thank you very much. And I will stop sharing my screen, and it gives me great pleasure to introduce Dr. Judith Wong, who would now talk to us on the diagnostics part of dengue and the challenges we have, and which are the best diagnostic tools right now we have. So over to you, Judith.
Thanks, Dr. Raman. Good morning, good afternoon, good evening, everyone. We'll wait for the slides to come out. Thank you. Firstly, thank you to WHO for the invitation to share our experience, and everyone for your time. I will be providing an introduction of dengue diagnostics and the opportunities and challenges that we face presently. Next. So on dengue diagnostics, one important difference that most of us would know is that compared with diagnosis of other viral infections, because we may be infected by multiple dengue serotypes over time, there would be a difference in how we look at the blood profiles between a premi and subsequent dengue infection. And so this is really important for us when we are thinking about dengue diagnostics. So in a premi case, after the peak in viral antigen, we would expect IgM to rise before IgG, while in a secondary or subsequent case, IgG would peak about the same time with the viral antigen and RNA peak. So expectedly, we do need to appreciate this difference when we think about using the tools for diagnosis and also how we interpret the diagnostic test result. Next. Next slide. So this chart provides a summary of the assays that we frequently use now in dengue diagnostics as well as surveillance, and I will take us through the types of assays that we have. So firstly, we talk about the rapid diagnostic test kits, which is the first one. And this is the one that is most frequently used for diagnosis currently, as they offer a very quick turnaround time. They are very simple to use. They are like a cartridge, almost similar to the ART test that we are familiar with for COVID-19, just that instead of doing a swab, we are putting in serum or a blood drop. However, with this rapid test kit, in our experience, we have observed that many of the kits have varied performances, and this is across kit brands as well as batches. Additionally, they may cross-react with other flaviviruses or anti-nuclear antibodies. For some of the kits that we have tested, we have also found a level of false positivity for IgM, as well as misleading IgG results. So while we are implementing this and taking this on as part of our suite of diagnostic tests, we do need to be mindful about the test kits that we use, and evaluation is really key in this regard. And I just put maybe state an example. For example, for the IgG band, some kits will state quite clearly that any detection is indicative or calibrated to a secondary dengue IgG level. However, some others are silent on this. So we do need to be very careful when we think about diagnosis, not to diagnose acute secondary dengue incorrectly. So we do need to do a level of evaluation for this test kit. So now I'll move on to the next suite of test types, which is ELISAs. And this is a common serological assay that we use for detection of dengue NS1, IgM, and IgG. And although this method takes longer than the rapid test kits, they do offer advantages to some level, especially when more samples need to be screened, and this could be used maybe in a regional lab or in a reference lab. Generally speaking, the test performance for this test platform is generally more stable, although cross-reactivity with other flaviviruses and anti-nuclear antibodies do exist. Now, the next common tool that we use, and it's one area that it's really rapidly expanding, as what Dr. Raman has shared, is that of PCR and molecular techniques. So they test for viral RNA, and because of COVID, many labs now have this platform, and this is really a good opportunity for us to pivot existing COVID-19 platforms for dengue diagnosis and surveillance. In terms of the test kits available, they do come in various forms, such as, for example, a pan-flavivirus screening tool. There are also triplex assays which offer detection for dengue, Zika, and chikungunya at the same time. And there are also more specific assays that test for dengue serotyping. In our experience so far, when we have evaluated a number of these test kits, there may be some trade-offs between test sensitivity and the number of targets. So for example, for some multiplex assays, they may be less sensitive than maybe if we look for just one viral antigen or viral target specifically. So hence the selection of the assay that we want to use for diagnosis is very important. We do need to understand the backdrop of arbovirus circulation in our respective regions of interest and our diagnostic or surveillance objective. So for example, if an area is, we know is endemic for dengue, but doesn't really have many chikungunya or Zika cases, there might be value in looking at a more specific assay, whereas in other areas where there are multi-arbovirus circulation, then perhaps a pan screening tool would be useful. Now, the last approach is that of sequencing. And again, COVID-19 opened up opportunities for us to tap into this capability for dengue surveillance as well. And although the turnaround time does take longer and it's not used routinely for diagnosis, it could be very helpful for surveillance as it provides high resolution data for us to understand what is happening. Next slide. The next slide, please. So right now, I will share some challenges which we have encountered so far in the area of diagnosis. And these are really some practical handles which we've picked up along the way. And I think it would be important for us to be mindful about, especially now that we do see dengue as an expanding epidemic. So we have evaluated a couple of dengue test kits in our experience. And for example, in the first paper here, we found that there were cross-reactivity with Zika, which is a flavivirus, as well as chikungunya, which is an alpha virus. So these results, though not surprising, it's really an indication that we need to be mindful when we are thinking of adopting a test kit, and that evaluation is critical. In the bottom panel, we did the reverse. Conversely, when we evaluated Zika test kits, again, we found cross-reactivity, but this time when we used dengue positive samples. So it is a common problem, but there are opportunities, there are solutions, and there are also test kits which have better performance. So we do need to be mindful about what would be useful for our context. Next. And over here, this is also another example to say that, you know, apart from serological assays, molecular assays are also not spared, in the sense that there are also limitations in performance. So in this report here, we found that our primer probes, which used to work for most dengue sequences, didn't work for a cohort of samples. And when we did a deep dive, we then realized that it was because of virus mutations, which resulted in a less sensitive primer and probe binding assay. So this again emphasizes the need for us to really understand what is circulating and to avoid detection dropouts. Next. So with that, I will summarize how we can integrate diagnostics and surveillance tools together into a workflow for early warning and to guide vector control. We have established a surveillance system together with the Ministry of Health in Singapore, where samples which test positive from different diagnostic labs are sent to our lab or the Ministry of Health for serotyping. And serotyping of positive samples, the results are then sent to the Ministry of Health, as well as the vector control operations team in our ministry, which is the Environment Agency, to guide vector control operations. Additionally, test negative samples in our diagnostic laboratories are also screened for flaviviruses and chikungunya. So this provides an enhanced surveillance for other arboviral diseases which may not be circulating, but occasionally we do experience sporadic cases. And this surveillance platform really helps us to pick up some of these cases in an early way. Next. So this slide shows how we use the serotype data. So we may ask ourselves, what is the use of doing serotyping PCR? Traditionally and historically, we have seen that every time we have a serotype switch, they may precede a dengue outbreak. Hence, the monitoring of serotype switches do help us to understand the situation, and it serves as an early warning for us when it could suggest that there could be a surge in cases. So when we do see the trend of a serotype switch coming along, then in Singapore, we would actually alert, for example, the community as well as premises owners to make a conscious effort in reducing breathing spots and to take precautions against dengue. And collectively, this would help us to avert certain outbreaks. And so with that, I end the presentation on dengue diagnosis, and I thank you for your attention.
Thank you so much, Judith. Thank you very much for an excellent presentation. Let us move on. Our next speaker is Dr. Lucy Lum, Professor of Pediatrics, University of Malaya, Malaysia. Over to you, Professor Lucy.
Thank you, Dr. Rahman. Can you hear me?
Yes.
A good day to everyone around the globe. It's good to see all of you. And thank you, Dr. Rahman, for inviting me to share my experience on case management of dengue. Now, when we looked at case management of dengue, we really need to put all the signs and symptoms within the context of the clinical cause of the disease. That's the only way for us to be able to make meaningful interpretation of the signs and symptoms. So the disease, I'm not going to talk about the incubation period, but it's a very important period.
Can you please upload your slide? Share your slide.
Share. Okay, sorry. Can you see it now?
Yeah, please put it on presentation mode. Yeah, fine.
So whenever we, talk about dengue management, we need to put out the context of the signs and symptoms within this clinical cause of the disease. So during the incubation period, which I'm not going to talk about, but changes are already occurring in the body that determines the changes that we see in the peripheral blood film in the following days. Now, after the incubation period, there's a high viremia, and this together with this is the start of the fever. So during this phase, the fever is very high, and there are the viremic symptoms, and this phase lasts, the minimum is 72 hours. All right, and this phase of the fever with the viremia symptoms is not distinguishable from other viral diseases such as the COVID, influenza, or the adenovirus. So the only way to recognize the disease around this at this time is to do a diagnostic laboratory test. Right now, once past the 72 hours, so if the patient is going to go into the critical phase, he will transit at about the time of the fever coming down. So during this phase, there are two phenomena that make the disease critical. One is the increased capillary permeability leading to plasma leakage and bleeding. Now, this phase is self-limiting. It lasts no more than 48 hours, and past the 48 hours, the patient then transits into the recovery phase. Now, the recovery does not refer to the recovery of the thrombocytopenia, but recovery of the plasma leakage, and therefore there is reabsorption of the fluid that has leaked out. All right, so now that we know the cause, we know that this is a very dynamic disease, and there are clinical problems that are unique to each phase. So the first 72 hours, minimum is 72 hours. Anytime after the 72 hours, the patient goes into the immune phase of the disease, where the severity of the disease declares itself. Now, during the viremic phase, the main problems are related to the high fever and the viremic symptoms of nausea. And very quickly, the patient develops dehydration and become at risk of electrolyte imbalance and energy and fluid deficits. Now, if they have comorbid conditions such as diabetes, all these will play into this dehydration and exacerbate it. Now, during the immunological phase, this is the critical phase of disease, as we've mentioned. These are the things that, these are the problems that determine the severity of the disease, the plasma leakage, bleeding, and organ impairment. And then after that, the patient transits, after 48 hours, the patient transits into the fluid, into reabsorption, and there could be a risk of fluid overload if the doctors are not aware of that the patient has actually moved on. Now, in the past and even now, we are making the diagnosis, recognizing the disease during the critical phase. And it's not difficult to understand why, because during the first 72 hours, the disease is indistinguishable. And even if patients present early, the full blood count is going to be normal. But at this phase, during the critical phase, the platelets have dropped and the hematocrit has gone up. Now, it may take a while for the lab diagnosis to be made. And during this time, the doctors may not be aware that they are dealing with severe dengue in the critical phase. And if on top of that, the problems that had occurred during the viremic phase have not been resolved, now they will just accumulate and become more during the so increasing fluid deficit, energy deficit, and if they have comorbid conditions, and added on top of that, the drugs that have been used like paracetamol and NSAIDs, this is really going to create conditions for a perfect storm. And added on top of that, the first few hours of that critical phase, the doctors may not be aware that they are dealing with a severe dengue because the platelet counts may take a while to come back, 1 or 2 hours. So during this time, they may be not only in a perfect storm, but they are flying in the dark. So really, the patients are not going to get very good outcome if we are recognizing the disease at this phase. So we really need to leverage on what we have nowadays, which is the ability to make an early diagnosis and be more proactive and take an integrative approach to disease in case management. So I'm going to talk about the phase of the disease, the problems, and how we should manage. So during the febrile phase, the first 3 days of fever, high fever, risk of dehydration, we need to quickly make a diagnosis, confirm the diagnosis of dengue with a rapid diagnostic test, establish the baseline hematocrit so that we know where we are in terms of patient's baseline, and do a risk assessment for any comorbid conditions, and if they are present, to consider early admission for stabilization, okay, at this phase, even in the early phase, not for an IV drip, but to stabilize their underlying diabetes, renal failure, and other diseases. And this phase should be managed with intense oral rehydration with electrolyte solutions. And if any antipyretics are used, we should be really careful with this. And if patients are not admitted, they need to be educated on the warning signs and what happens when the fever comes down. Otherwise, they may not be able to connect the dots that the fever of 3 days ago and the symptoms now are actually related. Right, and if possible, identify the hospital for the emergency treatment and daily follow-up for the hydration status and progression to severe disease. Now, during the critical phase, I've outlined the problems. So we need to identify these quickly with a hemodynamic assessment and a prompt resuscitation with crystalloid and colloid titrated to a therapeutic endpoint. And if bleeding is recognized, we should prioritize urgent transfusion of fresh PEG cells and red blood cells. Now, the glucose and the electrolytes got to be maintained throughout the illness. And if they have comorbid conditions, this have to be addressed aggressively. Very, very important. All right. Now, as for iatrogenic problems like fluid overload, excessive fluid accumulation, the key here is to prevent it from happening. And this, we can do that by observing the 4 phases of fluid resuscitation and to de-escalate fluid therapy below the maintenance fluid before stopping the IV drip. Now, during the reabsorption phase, we need to de-escalate the fluid and use minimal IV fluid to maintain the electrolytes and correct the electrolytes with just minimal fluid. So to summarize the fluid therapy and phases of dengue, in terms of fluid therapy, during the viremic phase, the oral fluid therapy should be a prescribed fluid therapy, meaning that we need to identify the amount of fluid patients need to drink, how to achieve that amount, what type of fluids they should drink, and then, if possible, document it so that we know exactly where we are. Now, during the critical phase, if they develop shock, obviously intravenous fluids will be indicated, if not oral fluids, and with frequent review of the situation. Now, this is very self-limiting at this point. It doesn't need to go on forever. And then the patient transits into the recovery period. We need to switch off the IV drip and get back to oral fluid again with careful monitoring of the electrolytes. With this, I'd like to thank you for your attention.
Thank you very much, Professor Lucy. We are running a bit behind schedule. So Samira, may I request Dr. Samira to talk on vector control now, please? And kindly keep to 7 minutes. Thank you.
Hello, everyone. Thank you very much. I'm going to be now starting. Can you see my presentation?
Not yet.
Can you see it now?
No.
Okay, let me share again.
Yeah, it's coming. It's coming. Yeah, put it on the presentation mode. Yeah.
Yeah. Now it's clear?
Yes. Yes. Please go ahead.
Okay. Thank you. So both Aedes aegypti and Aedes albopictus are highly invasive and continue to spread, as seen here in this map of the Eastern Mediterranean region. Particularly Aedes aegypti is spreading within the countries to new areas with reported dengue cases. Aedes aegypti is present in 11 countries and they report dengue cases. In the graph here, we see here in the graph, the number of reported dengue outbreaks are increasing as seen in 2019 and continue to increase, and we are still approaching the transmission season. So available vector control approaches that have been used to control dengue and other vector-borne diseases can be effective if implemented well and sustained. Vector control aims to reduce the populations of vectors and or reduce human contact with vectors. For some vector-borne diseases like dengue, effective treatment or vaccines are lacking. Hence, prevention through vector control is the only control option. You see here we have chemical and we have non-chemical. So chemical, these are insecticides used to target the adult stage and also the immature stages like the insecticide-treated nets. And we have also the spraying of insecticides and larviciding. There is a list of WHO pre-qualified vector control products to select from. These are recommended as they have been assessed to meet the global standards of quality, safety, efficacy. The efficacy also depends on the susceptibility to the targeted disease vectors. To target the adult stage using insecticides such as in the impregnated bed nets and also the chemical larvicides. Topical repellents may also be beneficial as an intervention to provide protection against dengue. The non-chemical is focusing on environmental management, source reduction, and I'll show you in the next slide the examples for source reduction. And also we can use in some cases larvavirus fish as a potential biological control to reduce the immature stages of the dengue vector. However, due to the study design and quality issues, further investigation is needed to generate evidence for impact of larvavirus fish. So therefore, there is no single intervention that is most effective, and programs apply integrated combinations of interventions that are most appropriate to the situation and require the local national government support and intersectoral collaboration. That is to say, bringing together the health sector and other relevant sectors. So I bring here, these are examples of breeding sites from the Eastern Mediterranean region. So the gravid female Aedes aegypti deposits its eggs inside a variety of man-made habitats, household containers, water storage containers, and objects inside and around houses in the urban setting. Aedes albopictus uses both urban and rural habitats. Tires are very attractive. The preferred dark color and the shade attracts the Aedes aegypti to deposit its eggs and use as breeding habitat, like this picture here, where this tire was used to shade a plant, and we found many Aedes aegypti. Eggs are laid one by one in breeding sites, and a full batch is spread over several breeding sites. These are waterproofed eggshells capable of resisting desiccation, drying out, and unhatched eggs are viable for months, up to 8 months. And in the absence of water, upon contact of water, they hatch and they emerge they release the larvae, which grows into pupa, then adults. So the most productive have been air conditioners, these old air conditioners, also the clay pots known as ziers, locally made, the water coolers, and also discarded objects, and of course the tires. So source reduction, that's to say destroying, removing, or treating all potential breeding habitats, and therefore reducing adult mosquitoes in all areas affected by or at risk of dengue, engaging and mobilizing communities. This is really important for the sustainability of vector control. These photos showing raising awareness on dengue and transmission and source reduction, and encouraging householders to conduct as a family activity, a community activity. These photographs show how community involvement to prevent mosquito breeding in locally made ziers by community-made covers or scrubbing the containers to remove the eggs. Photos also show female community volunteers removing unused tires and using them for building walls, as we see here in this photo. In addition, application of chemical and biological larvicides to water storage containers and other larval habitats can be effective in reducing immature vector populations. WHO pre-qualified larvicides are also recommended. Deploying of surveillance tools like gravity traps can be used for surveillance, including to monitor the impact of vector control activities, and as a control, these traps reduce the adult Aedes density, including infective Aedes mosquitoes. So this is quickly just to show you the spray spraying aimed to suppress ongoing epidemic or prevent an incipient outbreak of Aedes-borne disease by a massive rapid destruction of infective adult mosquito population. Outdoor fogging has no or very limited impact on disease transmission. So indoor fogging is more effective if applied every 2 to 3 days for 2 weeks than every week for another week. WHO pre-qualified recommended insecticides. You see here, there's a website which gives you the best effective insecticides. However, there needs to be insecticide resistant monitoring to identify and to procure the most suitable, which is accessible insecticide to the local Aedes population. Another challenge we have is currently the invasive Anopheles stephensi, and this has been spreading outside the established region. It's an important urban malaria vector, a major malaria vector in Afghanistan, India, Iran, Pakistan, and a primary vector in Djibouti following its establishment. So this Anopheles stephensi is very close breeding with Aedes aegypti. They have common breeding sites. The main challenge is that Anopheles stephensi also proliferates in the urban sites in this, as I said, in the similar human-made habitats, and have been found to coexist with Aedes aegypti. This increases the burden on vector control programs. However, there's an opportunity for an integrated vector surveillance and control, especially through source reduction. So the challenges, these are the challenges for vector control. The limited expertise in vector control program management and surveillance has issues for implementation for integrated vector control management. There's many challenges, as we see here: the human resource shortage and capacity, inadequate coordination and collaboration, the high turnover of qualified staff, the extreme climatic events leading to spreading of invasive vectors, limited options for low cost of insecticides since we have increasing insecticide resistance, poor community engagement, which is really important for sustainable vector control in controlling Aedes-borne diseases, and also the Anopheles stephensi. In the challenges for Anopheles stephensi, there's gaps in knowledge on distribution, behavior, bionomics, and effective control of invasive vectors. The role of these invasive Anopheles stephensi and Aedes aegypti in the local transmission. As I said, insecticide resistance and limited resources, human and financial. And thank you very much.
Thank you very much, Samira. Thank you very much for a comprehensive presentation. Let's now move on to Dr. Giovannini to talk on community engagement. Over to you, Giovannini. Please note, Giovannini will speak in Spanish, so kindly use the interpretation available. Samira, can you
presentation?
Samira, can you please stop the slide, sharing of slide?
Could you see my presentation, Ramon?
Yeah, it has come. Yes.
Yes.
Please put it in the presentation mode.
Bueno, muchas gracias. Buenos días, buenas tardes, buenas noches a todos que nos atendem. O tema que me toca hoy es hablar sobre la participación comunitaria y las acciones necesarias para su involucramiento. Yo empezaría inicialmente con una... Perdón.
Sorry to interrupt you, Dr. Giovannini. Can you please put
okay.
in presentation mode?
Excelente. Ok. Bueno, yo empezaría inicialmente con ese slide destacando lo tema central que es la participación comunitaria en la región de las Américas bajo dos modelos de trabajo aprovados por los países y que la Organización Panamericana de Salud lidera con apoyo de los países. La primera es la estrategia de gestión integrada para la prevención de las doenças arbovirales. Y la segunda, el Plan de Acción de Entomología y Control de Vectores. Estas dos estrategias tienen el tema de la comunicación y la participación comunitaria como temas transversales que deben y que trabajan junto con los distintos y diferentes componentes de la estrategia de gestión integrada, a ejemplo de la epidemiología, del cuidado del paciente, lo medio ambiente, laboratorio, etc. O sea, participación comunitaria y movilización de la comunidad es un tema central que orienta las intervenciones de lucha contra las arboviroses. Bueno, la Organización Panamericana de Salud tiene desarrollado una serie de actividades en apoyo a los países. Yo quería destacar una de ellas, que es exactamente la Semana de Lucha contra los Mosquitos, que es una semana de movilización en el continente, donde diferentes mensajes para la comunidad son desarrolladas. Y aquí yo tengo una mensaje específica para la protección de las viviendas, que, claro, cada país hace sus adaptaciones, y un outro mensaje específico para los viajeros como una medida preventiva. Y por último, también un mensaje clave a respecto de los signos de alarma, que especialmente para el dengue, que la población debe tener en cuenta y buscar los servicios de salud, identificar esses signos de alarma y buscar los servicios de salud. Bueno, en las próximas diapositivas, yo voy a presentar al menos 2 experiencias de países que yo considero muy interesantes e importantes y que reflejan, de alguna manera, la aprovación de la estrategia de gestión integrada, del modelo de trabajo de la estrategia de gestión integrada por los países. Un primer ejemplo es de Brasil, que es un país continental, responsável por casi 80% de los casos de dengue en la región de las Américas, que tiene un sistema de salud extremadamente complejo, pero que es capaz, bajo la reitoría del Ministerio de Salud, desarrollar mensajes claves y campañas de movilización que llegan a los distintos niveles de los sistemas de salud, sistema estadual y municipal. Y también trabaja con múltiples intervenciones y múltiples mensajes para diferentes públicos grupos. La próxima, otro ejemplo, viene de México, y aquí una experiencia local de la ciudad de Mérida, donde el concepto de manejo integrado de vectores utilizado nesta intervenção foi adotado, e donde, de uma maneira bem articulada entre os atores comunitários, as autoridades locais, se logrou desenvolver uma estratégia de reciclagem para o bem-estar da população. E um ponto importante que é fundamental nesse processo é que essa iniciativa também teve um processo de avaliação de impacto, utilizando métodos entomológicos, como meu colega apresentou antecipadamente, que demonstrou o impacto e a redução de los principais índices aéticos. Isto é um aspecto importante porque a demonstração do impacto dessas intervenções são fundamentais, por exemplo, para garantizar, de alguma maneira, a participação da comunidade. E, finalmente, eu trago uma última reflexão sobre o que necessitamos fazer para seguir nos movendo para garantizar a participação da comunidade. Este é um engrenagem complexo. Trabalhar com a comunidade não é uma atividade sencilla. E nesta diapositiva eu quero destacar 2 aspectos fundamentais. O primeiro, a necessidade de se ter programas nacionais fortalecidos para que o papel rector de los programas seja estabelecido de maneira que a produção das informações seja feita de maneira clara e bajo as evidências disponíveis. O segundo aspecto, de respeito ao fortalecimento dos programas locais de prevenção e controle das arboviroses. É fundamental, as pessoas vivem em nível local. Ter programas locais organizados e estruturados é clave para garantizar uma qualidade das intervenções. E, por último, a participação das comunidades, das famílias e dos indivíduos é clave para garantir a sustentabilidade de todas estas intervenções. Com isso, eu finalizo minha apresentação e, de antemão, agradeço muito, uma vez mais, a oportunidade. Gracias.
Thank you very much, Giovannini. Very interesting presentation. So basically, I wish to thank all the speakers for having such a comprehensive coverage of all the topics on dengue. We have had several questions, but we will try to answer them through email. Just to take a few of them, one on the vaccines, we may have another session on dengue later if time permits. Later on, we will include vaccines, but essentially the dengue vaccine, we know one vaccine is registered in over 20 countries. That is the Sanofi Pasteur one, but it has limitations where it works only if you are sure that you had dengue once, and it is recommended for an age group of 9 to 45. The second vaccine of Takeda is currently still under WHO review, and there is more work. The recommendation probably will come only by the end of this year, and we are hoping that Takeda vaccine also would come up for us, though it is being registered by few agencies. Few other general questions. Dengue mosquitoes do bite during the daytime, so we need to take care of yourself during the day. And in terms of immunity against the 4 serotypes, if you are infected with one serotype, you have a lifelong protection against it, but that does not guarantee cross immunity for the other 3. So after a couple of years, there is every chance that you could get dengue for a second time. And usually the secondary infections are more severe. So we need to be on guard. So I think I'll stop there. There are some interesting questions, many of which answers can be found in the dengue fact sheet in the WHO website, and others you are free to contact us on email and we will reply to you. Over to you, Agnesa.
Thank you, Raman. Thank you, everybody. As we're coming to the end of our allotted time, I will wrap up by saying thank you very much to all our speakers today, our interpreters, the WHO colleagues who have worked on this webinar, and the EPI-WIN team, Priya, Gianfang, Gabriella, Supriya team, overseen by Dr. Sylvie Briand. Finally, thank you to all of you for coming and for your questions. The recording of this webinar will be available at the EPI-WIN website. And if you want to keep updated on future EPI-WIN webinars, please subscribe to our mailing list. Both links will be appearing in the chat. We hope you will join us for our next webinar next Wednesday, 16th of August on Lassa fever. Details will be posted shortly on the website and sent to the mailing list. Thank you, everybody. Thank you again.
Thank you.
Thank you.
Thank you.
Thank you. There are lots of questions, actually. I feel a bit, do we have to answer them?